Hello, and welcome to the monthly EMS system lecture. My name is Bill Toon, and I'm going to be doing a journal article review for you today. The article I chose was Paramedic-Initiated CMS Sepsis Core Measure Bundle Prior to Hospital Arrival, a Stepwise Approach. The primary author is a Jason Walchuk, and he's a paramedic in the Greenville County EMS system. This article appeared in Pre-Hospital Emergency Care, 2017, Volume 21, Number 3. So hopefully you'll have a chance to actually read the article for yourself and glean some additional information that I just won't have time to cover in this presentation. And I'll share some other resources with you at the end of my presentation that I think that you'll find also beneficial. Severe sepsis and septic shock continue to be the leading cause of death in non-cardiac ICUs in the United States. To improve patient outcomes, the Center for Medicare and Medicaid Services implemented core measures that outline the initial treatment of the septic patient. I'll go over some of these when I actually focus on the sepsis alert used in this particular article. Now, you can see sepsis involves approximately 850,000 ED patients a year, and this was just recently published in Critical Care Medicine. We've also spent a great deal of time targeting STEMI patients and stroke patients, and you can see the numbers here that deal with this annually. So there's a high likelihood that you're seeing more sepsis patients than you are a STEMI and or a stroke patient in the routine care that you provide. This study was designed to answer a few questions this system wanted to know. One, could a paramedic accurately identify the septic patient without, this is very important, without point-of-care lactate results using a pre-hospital sepsis assessment tool called the PreSat or PreStat? Second, could uncontaminated blood cultures be reliably obtained during a field IV start? And third, could paramedics administer pre-hospital antibiotics without causing harm? And in this system here, they chose to answer positively all three of these questions before they would consider a permanent change to their system protocol for the care. This is a retrospective case series review of all 911 call patients that were identified as a sepsis alert in the pre-hospital setting from November 2014 to February 2016. All adult patients age 18 years of age and older who were evaluated by the Greenville County EMS paramedics who had a sepsis alert and were transported to one of two hospital systems within the service area. Now, Greenville County covers an area just over 785 square miles. It has approximately 480 to 90,000 patients. It's located in upstate South Carolina, which includes the foothills of the Blue Ridge Mountains in the northernmost portion of the county. Mixed rural suburban community with the largest city being Greenville itself. So they have 21 ALS units. They answer, or I should say, responded to 85,000 calls in the service area, average transport time of approximately 16 minutes. In its typical system, 911, pre-arrival instructions. They are staffed by at least one NREMT paramedic following operational clinical guidelines, no medical control needed. And again, all the patients that fit this sepsis alert were transported to one of four EDs that are part of two different hospital systems. Here's a little comparison when you look at MedAct versus Greenville and how similar they really are. The one thing I cannot explain is their increased call volume compared to population, because Johnson County has a larger population, and when we look at just ALS transport units, not first response, ALS first response, or other units, they're talking 17 in Johnson County, 21 in Greenville, and look at the paramedic number differences. So I found that very interesting. So the adult pre-hospital sepsis assessment tool was created using the 2012 Surviving Sepsis Guidelines. 4 systemic inflammatory response criteria which were used, which was tachycardia greater than 90, tachypnea respiratory rate greater than 20 or mechanically ventilated, hypothermia greater than 101 or hypothermia less than 96.8, and or signs of poor perfusion, systolic blood pressure less than 90. 2 signs and a known or suspected source of infection required the paramedic to issue a sepsis alert to the receiving emergency department. And when you look at this check sheet that they have there, very simple, this tool, it's not even something that needs to be initially done by a paramedic. Whoever arrives first, who has this high index of suspicion of sepsis, can use this tool and then share the results with the arriving paramedics when they come on scene. Now let's just go through a few details of this study, and then we'll get talking a little bit about the results. So all paramedics received education and skill training, which included sepsis identification, sterile blood cultures collection, and the use of the assessment tool. The training included in-service training sessions for a total of 12 hours, which was divided equally into 4-hour sessions on didactic, simulation, and skill stations. Competency was evaluated by passing a score of 90% on a written exam. Critical blood culture collection competency was evaluated by use of high-fidelity simulation mannequins. Remediation occurred for those individuals that failed initial competency evaluation until all providers achieved the minimum passing requirements. All providers were found to be competent in the clinical protocols and aseptic blood culture collection prior to leaving their assigned training session. Patient care protocol. A pre-hospital sepsis care protocol was developed in collaboration with an established EMS sepsis committee consisting of representatives from both hospital systems included in the study. This is really important for the success here. Is this was not just EMS. They really got all the players together to work on this to come up with what made sense, what made best sense for their approach here. And the support from the hospitals was very good in what the hospitals did for the crews. They put together little sepsis kits based on the hospital system. So based on where you were taking the patient, you'd grab one of these kits that already came prepared with the tools that you would need to be able to draw the right cultures for that hospital system and give the antibiotic that that hospital system wanted to work with. So all those supplies came together in a Ziploc bag with what was needed. In-hospital care was determined by receiving clinicians and was the current standard of care within that health system. So there was really no evaluation in this thing of what happened to the patient after their arrival, other than the fact that they were further evaluated to see if they met the criteria for sepsis. There were outcome measures. Primary outcome included agreement of a paramedic identification with an ICD-9 or 10 discharge diagnosis of sepsis, severe sepsis, or septic shock. And you can find this could be even a limitation, and we'll talk about that later, that the fact that they use the ICD-9 or 10 codes. Stepwise implementation of this process approach was used and incorporated the components of the core measure bundles. Each area of the bundle was evaluated consecutively in a way that would provide evidence for the next step. Step 1 included evidence of knowledge of skill competency, and the treatment protocol evaluation of the accuracy in identifying the sepsis alert patient correctly, and blood culture contamination rate for the period, and then the pre-hospital administration of intravenous antibiotics. Statistical analysis were really very simple, and when you get into the paper, you can see that they used very simple percentages of what was seen there's not a extensive or complicated considerations. So let's talk a little bit about the results with this program. It took place over a 14-month period. There was 120 paramedics trained, and they were called to 1,185 sepsis alerts on 57, almost 58,000 patients that were transported from the residence, nursing facilities, or from a medical facility for a sepsis alert. So this next chart actually breaks down for you the study population. And you can see at the top the total number of patients assessed by the Greenville EMS system, which was almost 58,000. They broke it further down about who was ineligible, meaning no medical trauma or age under 18. And then it left the group that was eligible, which was 1185. They excluded 153 because they were missing discharge outcomes, no IV access. So that left them 1032 that had IV. 86 were excluded because they were unable to get blood cultures. That left 946 that had blood cultures obtained. So that ended up being the actual study population, was the 946. So let's talk a little bit about the discharge diagnosis and serum lactate. So as we get down in here, we get down to our actual number, this N equals 845, and this is the continued breakdown from sepsis alert to those that were excluded. And it found out of 848 patients of the 1154 in this number that was reviewed had a sepsis discharge diagnosis. So sepsis was 50%, severe sepsis was 14.6%, and septic shock was present in 8.9%. A blood sample for lactate analysis was available for 702 patients. And again, a further breakdown showing that patients with an elevated lactate of greater than 2.2 to 3.9 was 33%, greater than 4 was 13%, giving a combined total of 46 that had a lactate that reached threshold in the sepsis criteria, and then had a list of ones that didn't. So what I like to point out here is I suffered sepsis about a year and a half ago now, and my lactate never got above a 2. So it shows up to 54% of your patients won't have an elevated lactate. And again, is it really necessary to have a lactate in the out-of-hospital environment to identify these patients? So the other thing over here, this little side chart here, talks about non-sepsis discharge diagnosis. Had pulmonary, UTI, COPD, flu, virus, cardiac CHF. You can see that there's a set of patients in here that didn't have sepsis, but the vast majority they were able to find did have sepsis. Now let's look just at the blood cultures that we had here. If you remember, I mentioned before there was 946. They had growth present in 24 or 25%, and 75% had no growth. Contamination was only in 47 of 179 non-contaminated. So appropriately acquired blood cultures was 95%, and contaminated was less than 5%. And that really answers an important question. Is it possible for blood cultures to be properly evaluated? Now, it would be interesting to see the comparison between blood cultures in the hospital versus blood cultures out of the hospital. Their contamination rate. So again, blood cultures were acquired on 946. 573 patients ended up receiving an IV antibiotic. So exclusion were prior field antibiotics, allergies, equipment failure, protocol violations, recent use of antibiotics, patient condition, or canceled by online medical control. And that's a very small number if you look there. So as we go down to the 573 that did receive an antibiotic, blood culture growth in 22%, non-growth in 77, contaminated growth in 27, non-contaminated culture growth in 100, and that gave 72% ended up getting a IV antibiotic that matched their bacteria, while there's 28 or 28% that were given that did not match their bacteria that they had. So this demographic chart is like impossible for you to read. You'll need to have the original article, but it breaks down things such as the sex. They're pretty evenly matched between male and female. Where did they come from? The greatest proportion came from residents, then nursing facilities, medical offices, and then it drops down after that. They looked at the serious criteria for heart rate, respiratory temperature, and hypotension. And the two greatest impacts here were heart rate and respiratory rate. 92% for heart rate, 87% for respiratory rate. And the respiratory rate, they talk about 22 or greater. There's also systems that are using end-tidal CO2 as another marker of the potential for sepsis. So that may be something that can be considered as an additional measure that could help refine possibly a sepsis alert tool even better, is including end-tidal CO2. And then again, it continues to go down between how many had IV access, blood cultures, how many received antibiotics. ED agreement with a sepsis alert was 94%. So that's very high that the ED agreed with the out-of-hospital diagnosis, which is really good. And then again, we already talked about this before. It talks about all the different ICD-9 codes, and the greatest number you're looking at are for sepsis, severe sepsis, and septic shock. So very good. Here's the primary source for the infection for the sepsis, pulmonary being the highest, followed by urinary, unknown, and you can read the rest there. So some important things, though, to discuss here are limitations. And limitations are really put some things in perspective. So it's a single EMS system. So is it generalizable to every EMS system in the country? It's a third service paramedic only system where they're able to do extensive continuing education, QA for their paramedics. It's retrospective case series, so there could be questions about missing data, except they controlled a great deal for missing data here in this study, so that may be less of an issue as it relates to EMS. In-hospital care was not specific in this study. ED and hospital clinicians continued their respective institutional protocols and stuff. Hospital laboratory analysis to determine lactate levels relied upon each receiving facility's standard of practice. So again, not knowing what was done at the hospital end. Only ICD-9 codes were used to identify patients. There could have been others that were missed. It all depends on how well the patient was coded in this process. And then this study was really designed to determine if EMS personnel could initiate the CMS sepsis core bundle successfully. There was nothing in here that talked about patient outcomes. So did it make a difference that it was started in the out-of-hospital setting versus the in-hospital setting? So in conclusion, this study demonstrates the successful implementation of an EMS-driven CMS sepsis core measure bundle in the pre-hospital setting. Paramedics can acquire uncontaminated blood cultures and safely give antibiotics prior to hospital arrival on patients who are recognized as needing a sepsis alert. Some other resources for you to look at. In EMS World magazine, there is a review of this article done by Dr. Fernandez called Improving Pre-Hospital Sepsis Care. Also, the August Journal Club of the Pre-Hospital Care Research Forum reviewed this study, so that's an opportunity to get some more. And I've really become a fan of the podcast done by Scott Weingardner called EM Crit. And if you go in there and search sepsis, you'll come up with probably a dozen podcasts discussing sepsis and just the challenges with sepsis, even within the hospital environment. So I want to thank you for taking the time to listen to my presentation. While might not be the most exciting thing, I believe that this is an opportunity for you to take this tool and at least have a higher index of suspicion that these patients could be septic, and then you can, on arrival at the hospital, you can help the hospital identify these sepsis patients earlier so they can meet their goal-directive therapy. And who knows, this study or studies similar to it could help change practice within the county alone. So just look at the potential here. So again, thank you though for taking the time to listen. If you, for some strange reason, want to contact me directly, you can do it through my Gmail account. Very simple, wftoon@gmail.com. And then again, please make sure you fill out the rosters and email it to the email address there. Make sure you do give feedback. I'd love to hear what you had to say, and you can say that it was absolutely boring and you're not going to hurt my feelings or anything. Thanks again, and continue to do the good work that you do. And yes, I do miss working with all of you. Thanks.